السلام عليكم.
وعليكم السلام ورحمة الله.
والسلام.
وعليكم السلام.
السلام عليكم boss.
Alaikum salam.
Okay, guys, today inshallah we will go for pediatric session part 2. Again, pediatric chapter is very important in the exam. Again, already you have the channel for resources. I wonder not all people they joined the channel of resources. It's not mandatory to go through all guidelines and flowcharts, but at least if you need any information, you can go for your target. For example, you are studying pediatric, so you can go for SLO 5 and then you can reach your topic. Okay, this is how to study. I want you to focus on resuscitation, to focus on pediatric, focus on trauma, focus on anything relevant to anesthesia, sedation. Okay, these are the most important chapters in the exam. Okay. Okay, for pediatric, as we mentioned, these are the most important topics in pediatric. So I want you guys to put paper like this and finish topic by topic. For example, brew. I want you to study brew, finish, go for study protocol, and so on. You have to study like that. Each topic you have to finish. Whatever from Arkham learning, from Arkham guidelines, or anything. So last time we talked about brew Sodic, and we finished insulin Berbera before group, post-tonsillectomy bleed, pyloric stenosis and intussusception. Kawasaki we finished in previous chapters. Limbic child, it's a very important topic. And today, neonatal emergencies. Okay, so delivery and the resuscitation of the newborn, it's a very important topic. So newborn resuscitation, it's very important in any SBA or any OSCE. Neonatal sepsis, important. Cyanotic, non-cyanotic congenital heart disease, at least you know the most important and the common topics, like for example, VSD, ASD, patent neonatal duct, and so on. Sedation, pain and sedation, very, very important, especially in pediatric, because it's a challenging topic. Pharmacology poisoning also, it's very important, especially batteries. Okay, of course we discussed before carbon monoxide, cyanide, organophosphate, toxidromes, but I want today to focus on batteries because it's a very, very important, and you have to follow the flow chart. Bronchiolitis, it's a very important topic and common. Okay, so the first question, 36-year-old woman presents to emergency department in active labor, Shortly after her arrival in the ED, baby boy is delivered. So they can ask you an Apgar score as well. Okay. So what do you think, guys? What is the Apgar score here?
Five.
Okay, so you should justify your answer. If the patient completely pink, so it's a 2.
Yeah.
If the patient heart rate less than 100, it's 1, so total 3 now. Grimaces when stimulated, it means 1 also. So how much now? 4. Floppy, so floppy, it means 0. So slow respiratory effort, it means total 5, right?
Yes.
Okay, so they said here grimaces when stimulated. So which is first, stimulation or Apgar score?
Stimulation.
Stimulation first. So dry, rab, stimulate before assess. Clear? Okay. So you have to stimulate the baby first, because sometimes if you stimulate the baby, his appearance will be normal. Sometimes if you stimulate the baby, his heart rate will be normal or pulse rate. Sometimes if you stimulate the baby, he will cry. Okay? So don't assess Apgar score without drying, without wrapping, without stimulating. Okay? What is the borderline of weeks for term and preterm? What do you think, you guys?
32 weeks.
32.
Yes, 32. It's a preterm or term?
Preterm before 32. After that is
Okay. So take care. Why? Because if the patient is preterm, you have to keep undried. If the patient preterm, you have to keep undried. If
yes,
the patient term, you have to dry.
dry and warm.
Yes. Okay. Which feature is not part of Apgar score?
Oxygen saturation.
Oxygen saturation. D.
Yes. So skin color, it's already included. Pulse rate included. Muscle tone included. Reflex to stimulation. So again, the reflex to stimulation. So stimulation first before Apgar score. Oxygen saturation is not included. Why oxygen saturation not included, guys?
Only we depend on respiratory rate, not on oxygen saturation when we assess the newborn.
It will improve slowly. It doesn't show up immediately.
Because oxygen not important in newborn, okay?
Yeah.
Accepted oxygen saturation like 65 within 10 minutes. Can you imagine? If the oxygen saturation is 65 within 10 minutes, okay, no problem. Do you need to give the patient oxygen if his oxygen saturation 65? No need.
Oh,
Any newborn, don't give oxygen, okay? That's why oxygen saturation, it's not part of Apgar score. Most neonatal deliveries that require resuscitation are corrected by which of the following management steps?
Warm, dry,
Warm,
and
Dry stimulation.
It's E.
Option E.
Why,
E.
why you choose E? Sometimes the patient is preterm, right?
Yes.
But they said here most, right? It means
Oh.
not all. Because most people or most newborn, they are term, okay? So warming, drying, stimulation. Do you need to give fluid to any newborn? Is it
No.
No.
glucose? No.
No.
Bag mask ventilation? Sometimes when to give bag mask ventilation? What do you think, you guys?
After dry and
After period.
start to clock and after assess, then if no response.
In
Bag
A,
mask ventilation.
okay, I will give you options. In A, B, or C?
B.
B.
No, in C.
C.
In C.
B.
No, in C.
Oh.
If it is place on
In all resuscitation, you can use bag valve. Please mute your mic, guys. In all resuscitation, ALS, ATLS, ABLS, you can use bag mask ventilation in B to increase RR or to optimize oxygenation. But in newborn, you can use bag mask ventilation in C only. Okay, if the heart rate less than how much?
60.
60.
Less than
60.
60. Okay, but in B, if B is abnormal, you will use bag valve mask ventilation or inflation?
Inflation.
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 The lung is collapsed.
Reflection.
The baby just born now and his lung is collapsed. That's why you have to inflate like balloon. You have to inflate the lung. Okay. After you inflate the lung in breathing, you will go to circulation and give bag valve mask ventilation. How many seconds for bag valve mask ventilation?
5.
1 second.
30 seconds.
30
So
seconds.
each ventilation in 1 second. Okay. Inflation, it will be 5 inflation breaths. 5 inflation breaths. Each inflation will be within 3 seconds. Okay. So remember that, please. So breathing, you have inflation. Circulation, you have ventilation. Okay. Intubation, do you need intubation here?
No.
No, no need for intubation. You can use intubation in case the airway not patent and you are using all maneuvers and still not patent. Okay. What is the next course of action? So baby is delivered in the emergency department 42. So term or preterm?
Term.
Set meconium stained fluid. The baby is hypotonic, so decrease the muscle tone, cyanotic, apneic, bradycardic. What is the next course of action?
warming, drying, and
Warming, drying, and stimulation.
Okay, so warming, drying, stimulation. Okay. Here regarding warming, drying, stimulation. After warming, drying, stimulation, if the patient is not responding, what you will do?
Positive pressure back and mask.
Head position and inflation.
You have to call for help. What
Yeah.
does it mean not responding? If I say the patient is not responding, no breathing.
Yeah. Assess.
Not crying.
Maybe the patient is in cardiac arrest. Okay, so if the patient not breathing before warming, drying, stimulation, what you will do? Warming, drying, stimulation. But if the patient is not breathing after warming, drying, stimulation, you have to call for help. Clear? Again, if the patient not breathing, if the patient is not breathing before warming, drying, stimulation, no need to call for help because you did not stimulate yet, right? Did you get my point, guys? If the patient is not breathing before warming, drying, stimulation, you will call for help or You will warm, dry, stimulate.
You won't transmit
Warm, dry, stimulate.
it.
After that, if the patient is still not breathing, you have to call for help. I wish it's clear. Okay. So, do you need to administer adrenaline here?
No.
When to administer adrenaline?
Only
In C.
C.
In C. If the patient is still heart rate less than 60, despite ventilation breath, despite high quality CPR also. Okay, regarding provide positive pressure bag and mask ventilation.
Yes.
So here the patient is bradycardiac. You can use positive pressure bag mask ventilation after warming, drying stimulation, and
Yep.
after inflation, right?
Yep.
So this action, it's not appropriate. Intubate, no need to intubate at the moment. Okay. So the first option is the accurate option. Okay. So you have dried. They said the baby is delivered. You have dried, warm.
Dr. Hadi,
Yes.
can we go to the previous question, please? Let me ask a question, please. Yes. After when if they have said a baby is born apneic, bradycardic, and after warming, drying, and stimulation, what's the next course of action? We see not be the next course of action.
After warming, drying, stimulation. What
Yeah.
else?
Yeah, we see if baby is still not crying, baby is still not breathing as expected. Are you not meant to provide positive pressure bag and mask ventilation?
No.
Okay.
Ventilation C. Ventilation C, not B. Clear?
Okay.
Here, warming, drying, stimulation is the patient is still not breathing or even gasping. Okay.
Okay.
So you
Yep.
have to go for inflation. One
Okay.
person technique, then 2-person technique.
Okay.
Okay.
All right. Sure.
Yeah. Then if
Okay.
the patient has chest moving, so you can go for heart rate. If the heart
Okay.
rate is okay, no need to do anything. If the heart rate is less than 60, you have to go for ventilation.
Sure. Okay. Thank you.
Dr. Ani, what do you, how do you differentiate between inflation breaths and ventilation breaths?
Yes, inflation, it will be within 3 seconds.
For 5 minutes.
Okay.
One inflation, it will be 1, 2, 3.
Yes, sir.
1, 2, 3. But ventilation, 1.
1
Done.
second. Okay.
Okay. So again, inflation in breathing, but ventilation in circulation.
Yeah. Okay.
Okay. The baby is not breathing. Is not breathing before or after stimulating?
After stimulating.
After.
Okay. You have dried, warmed, stimulated the baby and placed him in neutral position. The baby is not breathing. You give 5 inflation breaths. What does it mean? Inflation breaths, B or C?
B.
B.
That's why he said
Chest movement.
clear now?
Okay.
Okay. And then you have chest movement. Then he said no heart rate is recorded. What does it mean no heart rate is recorded?
Cardiac arrest.
It means C, right?
Circulation. Yeah.
C. What does it mean C? Inflation or ventilation?
Ventilation.
Ventilation.
What is the next course of action?
B. Continue to ventilate.
Continue to ventilate.
Clear now?
Yes.
Okay.
Actual protocol is you need to repeat the inflation breaths. No, honey. Is it not that you need to
Excellent, excellent. In breathing, you have to do 5 inflation breaths. Okay. Why he did not mention repeat 5 inflation breaths 2-person technique? Because already you have chest movement. He went to go for 2-person technique if no chest movement. Clear?
repeat? Okay. Oh. Okay, it's understood in the scenario. Okay.
Yeah. So if the patient has chest movement, you have to go for C. If the patient has no chest movement after inflation, you have to repeat inflation, but this time, 1 second, guys. Okay, guys. So here, B is okay, but C is not okay, right?
Yeah.
So
Dr. Ham, if no chest movement, what we will give another 5 inflation or ventilation 30 seconds?
yes, you have to go for 5 inflation breaths. This time it will be 2-person techniques. Okay.
Yeah, another 5. If no chest movement, another 5
But
inflation.
2-person technique.
2-person.
Okay. Okay. We will go for other options. Immediately start the chest compression.
No.
When to start the chest compression? If ventilation not responding, and then you go for
chest compression.
Clear now?
Yeah.
Okay. So immediately give IV adrenaline. I want to give IV adrenaline.
So if the heart rate is not improving in spite of chest compressions and ventilation.
Yes. So he want to start IV adrenaline. If the heart rate not responding to the first action, ventilation, and not responding to the second action, chest compression. Clear?
Okay.
So you will go for the third action, IV adrenaline. So in C, how many interventions? 3. Number 1, ventilation. Number 2, chest compression. Number 3,
Adrenaline.
adrenaline. Intubation, any problem in airway? Did they mention here any problem in airway?
No.
So ignore airway here. Okay. Okay. So we have option A for C, option B for C, option C for C, option D and E for A. Okay, what is the next course of action? Shortly after arrival, baby boy is delivered. You have dried, warmed, and stimulated the baby, placed him in neutral position. The baby is not breathing, so he's talking about A, B, or C?
B.
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 What is
B.
action for B?
Inflation.
Inflation.
5
Inflation breaths.
Yes, give 5 inflation breaths. Okay. What about chest compression? Is it for B?
No.
For C.
For C. IV adrenaline for B?
No.
Intubate?
C.
A.
A.
Apply high flow oxygen. Do we need oxygen in newborn?
No.
No need.
No.
Also,
Dr. Honey,
yes.
There are a lot of disturbances.
how many cycle of a chest compression do you do before you give adrenaline?
Yes, you have to. I'm not talking about this question.
Yeah.
I'm talking in general. In C,
Yeah.
you
Yeah.
have 3 interventions. Okay. In B, you have 2 intervention, right?
Okay.
5 inflation press 1-person techniques, then 5 inflation press 2-person techniques. Clear?
Yep.
One?
Yep.
In C, you have 3 interventions. Number 1,
30
ventilation.
Yeah.
Then number 2, chest compression. Then number 3, IV adrenaline.
Okay. Okay. So you do chest compression 3-1, just one cycle, then you give adrenaline. Is that correct?
Yes. So number 1, you will do ventilation breath 30 seconds, 30 times.
Yep.
Then check the heart rate. Still less than 60. Then start the chest compression without medication.
Okay.
Then after 30 seconds, check the heart rate. Still less than 60. So you start chest compression again, but this time with adrenaline.
Okay. All right. Sure.
Okay. So number 1, ventilation. Number 2, chest compression without medication. Number 3, chest compression with adrenaline.
Okay. Sure. Sure. Thank you.
Welcome.
Dr. Hani.
Yes.
Sorry for the interruption. This is a general message. Guys, so many mics were turned on. I'm very, very sorry. There is a lot of disturbance behind. Please be considerate. Please turn off your mics. Thank you.
Yeah, please mute your mic, guys. Okay. If you want to answer, you can unmute your mic. Okay. So regarding adrenaline here, it should be how much mics?
20 microgram.
Okay. Okay. So if you have children beside you guys, you can mute your mic. No need to answer. Okay, what is the next course of action? Here, you should check the baby is term or preterm. If not mentioned, it means it's not important for the exam. The baby is still and silent. Before or after drying?
Before.
Before. So
Before.
you have to dry. You dry and wrap the baby and wrap him in blanket. After drying, the baby is not breathing. So he's not breathing before drying and not breathing after the drying. What will you do?
Call for help.
Call for help.
Open airway. Open airway.
Call for help. Call for help. Okay. So if the patient is not breathing in the start, you can wrap the baby and keep warm. Then check the baby. Still not breathing, so you have to call for help because this patient maybe he will not respond. You have to call for help. They will prepare all equipment and they will help you also. What is the next course of action? The baby is not crying. Take the baby, dry hair, wrap hair in clean towel. 39 weeks. What does it mean?
Term.
What is the next course of action after dry and wrap?
Assess the tone, bleeding, and heart rate. Heart rate. Up score.
Yes,
Yes.
score. So after drying. Okay. What is the recommended compression to ventilation?
3:1.
A.
Okay. What is your next course of action? They said the baby is delivered 38 weeks, so term. Okay. The baby is not crying or breathing.
Shouldn't he?
Dry baby.
Right.
Give.
Dry baby.
Dry the baby.
Dry the baby.
Right. Maybe after drying, the baby will cry. Okay.
Mm.
Maybe he will breathe. So if breathing after drying is still not breathing, okay, what you will do?
Call for the help.
Call
Call
for
for
help.
help. And then
Call for help.
Give 5 inflation breath.
Rescue
yes,
breath.
of course, if airway is open also. Okay. 7-day neonate, fever, drowsiness, difficulty feeding. If you see this scenario, you can imagine maybe neonatal sepsis, maybe congenital anomalies. I will not say congenital heart disease, right? Because congenital anomalies can be congenital heart, congenital diaphragmatic hernia, congenital lung hypoplasia. So you can think about these differential diagnoses. So heart rate is 165, RR70, temperature 38.7. Do you think if the patient has congenital heart problem or congenital anomalies, he will get temperature?
Oh.
No.
So which of the following investigation is the priority?
Blood culture.
Urine
and
deficit.
Number.
C.
Is blood culture. See.
Yes. So any patient with neonatal sepsis or suspected neonatal sepsis, you can think about blood culture and the lumbar puncture. Actually, blood culture more than enough. Lumbar puncture, if the patient has severe sepsis. So do you think this patient has severe sepsis?
Yes.
Yes.
Clinically
Yes.
dehydrated.
Yes.
Dehydrated, mottled baby. So you can order also lumbar puncture.
Dr. Ani, is it because the baby is less than 3 months falling into severe category, you recommend blood culture and lumbar puncture?
Here, neonatal sepsis, you have early neonatal sepsis and delayed neonatal sepsis. What is the difference between early and delayed neonatal sepsis? Any idea, guys?
Early within 24 hours.
So less than 7 days early onset and after 7 days to till 28 days late onset.
Yes. So if less than 72 hours, it's the early onset neonatal sepsis. If more than 72 hours, it's a late neonatal sepsis. So here you have to be familiar with investigations. Okay. So here this is the difference between early onset within 72 hours and the late onset more than 72 hours. This topic is very important in the exam. Okay. So you have to differentiate between both of them from the scenario. You check the age. So 7 days, it means it's a late onset. Okay. You have to be familiar with the organism also, because according to the organism, you will give the antibiotic. So in group B, Streptococcus, Escherichia coli, most common organism in early. Okay. And regarding late, remember that negative staphylococci, Enterobacteria, Staphylococcus aureus. Remember that. Regarding the clinical indicators, how to understand this patient, he has sepsis or not, early neonatal sepsis or not. So for early, if you find altered behavior or responsiveness in the scenario, so it's a sepsis. If you find altered muscle tone, feeding difficulties, intolerance, abnormal heart rate, signs of respiratory distress, hypoxia, pulmonary hypertension, jaundice, signs of neonatal encephalopathy, temperature, whatever less than 36 or more than 38, unexplained excessive bleeding, altered glucose, metabolic acidosis, and the age less than 72, so you think about early onset neonatal infection. And here regarding late onset, so check the behavior, respiratory, circulation, skin, and other. Sometimes they will give you options. They will give you which of the following criteria indicate late onset neonatal infection. So if you find, for example, mottled appearance, so you can choose. If you find the cyanosis or skin, lips, or tongue, so you can choose. Non-blanching rash, you can choose, and so on. So please be familiar with these slides. Regarding investigation, as we mentioned, you will, before starting antibiotic, you can perform blood culture, the most important. Did they mention blood culture or lumbar puncture?
Both.
Blood culture. Okay. You can do lumbar puncture, okay, in severe cases. Okay. So a strong clinical suspicion of neonatal infection or the clinical symptom or signs suggesting meningitis. Otherwise, no need to do lumbar puncture. Okay. Regarding the antibiotic, what is the antibiotic, guys, for early and for late? Any idea?
Ceftriaxone and ampicillin.
Ceftriaxone.
For early onset infection, according to NICE guidelines, this screenshot from NICE guidelines. So early onset infection, you can use benzyl penicillin. Okay. What else?
Gentamicin.
And the gentamicin.
Gentamicin.
Remember that. So early.
Okay.
Benzyl penicillin and gentamicin. And regarding late onset neonatal infection, you can use
Ceftriaxone.
yes, ceftriaxone. Okay. Okay. What is the most appropriate treatment for this?
Benzyl penicillin, gentamicin.
2 days.
D.
Number 4.
D.
Why?
It's 2 days. It's
Less
less.
than 72
Hours.
72 hours, and the temperature more than 38.
Yeah.
Here also increase the CRT, and you suspect neonatal symptoms.
Dr. Hani, can you show the previous slide, please? For antibiotic 4. Sir, it is cefotaxime, not ceftriaxone in late onset sepsis.
In early, because 72 hours, benzyl penicillin and the gentamicin.
Yes, sir.
Yes.
But in late onset sepsis, it will be cefotaxime, not ceftriaxone.
Yes, they mention here treat neonate who are more than 40 weeks, correct gestational age, who present with community acquired sepsis with ceftriaxone 50 milligram. But regarding the young age, this more than 40 weeks. Okay, what if less than 40 weeks?
Ceftriaxone.
Cefotaxime. What is the most likely causative pathogen? So 1 week.
Oh, 1 week, that's
It's onset. Staph aureus.
Aureus.
E. coli.
Staph aureus.
A.
Escherichia coli.
Staph aureus is
No, E. coli is
late onset. E. coli is early onset.
it's early onset, yeah.
Okay.
E.
So
coli is early onset, yeah.
E. coli.
Yeah.
Okay. What is the most likely causative organism? 2 days.
GBS. Third one.
Group B beta hemolytic.
Group B.
Okay.
Group B strep.
What is the most likely diagnosis? So 2 days.
Early onset.
Irritable,
Early
not
onset,
feeding
so-
well. So until here, it can be congenital anomalies. It can be sepsis, right? Until here. Normal vaginal delivery, mother and the baby were discharged after 24 hours. Okay. So
Is
CRT,
the
2 seconds.
Early.
30.
Early.
What do you think, guys?
Congenital heart disease.
D.
Option D.
Early
onset sepsis, yes.
Yeah. Temperature less than.
But Dr. Hani, all the parameters are only temperature. Okay.
Yes,
Yeah.
temperature. Okay. So if you find any heart rate and the temperature and the patient irritable and not feeding well. Okay. Did they mention
Minor
murmur here?
congenital heart disease.
Did they mention murmur here? They said examination is normal. What does it mean, examination normal? It means the heart is normal and the lung is normal. Clear? Okay. Which of the following is acyanotic? Acyanotic congenital heart.
Heterogeophalus.
Sorry.
ASD.
ASD.
D.
No, tetralogy of Fallot.
TOF.
ASD. TOF is
Cyanotic.
ASD.
The question should be, what is the cyanotic heart disease?
So which one is cyanotic? Which one is acyanotic?
Cyanotic, ASD, VSD. PDA.
All the
The
T's
person
are
said it's cyanotic.
Oh, it's the tetralogy of Fallot.
This one cyanotic or acyanotic?
Cyanotic.
Cyanotic.
You suspect
Cyanotic.
one of the cyanotic congenital heart defect. So do you think
But the question,
spelling here?
which of the following is A? I think there should be a gap. So it's
Option B is acyanotic.
Sorry, Dr. Wani, please, I have a question, please.
Yes.
Please, this A cyanotic, is the A separate from that cyanotic or they are joined together?
Yes. So here on examination, you find the murmur, right? They have noticed he turned blue when feeding. He is blue or blue when feeding. What do you think?
Blue when
He did not say he's blue. They said he turns blue when feeding. What does it mean, turns blue when feeding? What is called this spell?
Cyanotic spell.
Cyanotic.
Cyanotic spell.
Okay, so what is the diagnosis?
Tetralogy of Mallet.
Yes. Okay. So it's called tet spell. The patient, if not crying, he is normal. If not feeding, he is normal. But once you stimulate him, like crying or feeding, he will get cyanosis and peripheries only. So what is the diagnosis? Tetralogy of Fallot. Okay.
Yeah,
Honey, I
but
have a question.
the-
All these congenital anomalies of heart we need to know in details, or the specific points we need to know for the exam?
Actually, they will not test your skills in all congenital heart disease.
Yes,
They
that's
will.
why.
The most important tetralogy of Fallot,
Okay.
BSD, okay,
Okay.
ASD, patent ductus arteriosus. 4.
Oh, okay. ASD, BSD, tetralogy of Fallot, and PDA. Okay.
Yes.
Thank
It's not logic to ask you about everything. And be familiar with 5 T's.
Yes. 5.
Okay. So here, be familiar also for legend. So tetralogy of Fallot, it means ventricular septal defect, as you see, and overriding aorta, pulmonary stenosis, and resultant right ventricular hypertrophy. Okay. What is the initial investigation?
ECG.
ECG. So if they said what is the initial investigation, ECG or chest X-ray or echo, you choose ECG. If they said what is the gold standard?
Echo.
Echo. Okay. So you can choose ECG or echo. Chest X-ray, it's not an initial, not in gold standard. So think about ECG or echo according to the question. Okay. And
Dr. Hani, you mentioned the 5T. What do you mean?
What do you think?
5T.
One of them, tetralogy of Fallot.
Okay, yeah, okay. The sandwich, yeah, Hadis, okay. All right, yeah, understand. Yeah. Okay. Thank you.
Welcome. Which of the following increases systemic vascular resistance, thus producing left to right shunt through the ventricular septal defect associated with the tetralogy of Fallot?
Squatting. Squatting.
Squatting. Option D.
Squatting D.
Squatting, yes. So here, any patient will do squatting. It means he's trying to improve his circulation. Okay. What is the most likely diagnosis? Here they said poor feeding and breathless. business, and they said heart murmur. So heart murmur.
PDA.
Option B.
Machinery Momo.
PDA.
So continuous. What does it mean, continuous?
Machinery Momo.
Machinery murmur.
Yes, machinery. Okay, it will be like that. Okay, so beta.
Dr. Hani, for fellow, is this a cyanotic or aniscyanotic? The
What do you
previous
think, guys, T, what does it mean?
This is cyanotic.
Tetralogy, if followed, the patient has no cyanosis, but once he cry or you give him feeding, he will turn to blue. Clear?
Yes, sir.
This is specific to tetralogy of followed.
But he is a cyanotic, but yeah, and it's a cyanotic disease.
Yes, but I mean he's not cyanotic now. Once you give him feeding or he's crying, he will turn to blue. Clear? Okay. So here regarding continuous heart murmur, patent ductus arteriosus. In each scenario, they will give you clue. So if you find a continuous heart murmur, it's going with patent ductus arteriosus. So why patent ductus arteriosus will cause continuous machinery murmur? Because this murmur will be from high pressure to low pressure. Which is high, guys? The aorta or the pulmonary?
The aorta.
Aorta. Okay. So high pressure from aorta to the pulmonary, and high volume to low volume. Okay. That's why he has this murmur. Which of the following is the most likely diagnosis? So 3 months. 3 months, it's going with which diagnosis in congenital heart disease and the systolic murmur.
VSD.
Ventricular septal defect.
VSD.
Yes. Okay. So 3 months, do you think it will be patent ductus arteriosus?
No.
It will be closed, right? Regarding patent ductus arteriosus, it will be closed within 3 months, right? Okay. So here, difficulty feeding, becoming breathless, fatigue during feeds. On examination, you note tachypnea, respiratory rails, systolic murmur at the lower left sternal edge. Okay. So these are the symptoms of VSD. Which of the following is the most likely cause? 2 weeks. Difficulty feeding. They tell you that when she's feeding, her lips and skin turn blue and she becomes distressed and breathless.
B. Tricuspid atresia.
Tricuspid atresia.
Why tricuspid atresia?
Why? Any explanation, guys?
Cyanotic.
Cyanotic.
The patient turn blue, right? What does it mean turn blue? Cyanotic. And the cyanotic, you think about 5?
5 days.
5 days.
Clear, Abdullah? Abdullah.
Yes.
So cyanotic, it means 5 T's, okay? And tetralogy of followed the first scenario, they said turn to blue, and the only T in that scenario, tetralogy of followed, right?
Yes.
And here also the only T is tricuspid atresia. You know why you choose this one now?
Okay,
In
thank you.
the palate also, Dr. Hani, we have during the feeding there will be skin turns blue and even the tricuspid. So how to differentiate whether it's tetralogy of palate or it's tricuspid atresia?
Yes, but the patient now, the patient now is has cyanosis. So cyanosis, think about T. Okay.
T, but in tetralogy of palate also there will be during feeding, right?
Yes, tetralogy of followed, the patient has cyanosis during feeding and during, but did they mention here tetralogy of followed?
No. Okay. Yes. Got it.
The only T here, tricuspid atresia, and the previous scenario, the only T is tetralogy of followed.
Okay. Yes. Got it now.
What is the most likely diagnosis?
A. Congenital diaphragmatic hernia.
Congenital diaphragmatic hernia. Okay. Regarding pain management, the most important for the Royal College, non-pharmacological management and pharmacological management. Do you think they will test your skills in mild or moderate pain? No, they will test your skill in severe pain because you are emergency physician. Okay, so which of the following is most appropriate? Non-pharmacological. None.
A. Dressing.
Dressing, cold compression, and phlegm.
Yes, dressing, cold compression, and cling film. Involve parents, it's a non-pharmacological, right?
Yes.
Play specialist, non-pharmacological. So you have option A, option B, option E. In the exam, they said here most appropriate. So I want you in the exam to use your common sense. Here they not logic to say parent. Parents, it will be after dressing, right?
Yes.
Play specialist, it will be after dressing. So the most appropriate here is a priority for dressing because dressing, it will relieve the pain. Okay. The same question, but here pharmacological.
Nasal diamorphin.
Okay. So you have IV morphine, invasive, right?
Yes.
invasive.
Yes.
Nasal, it's a better non-invasive. Dressing, it's a non-pharmacological. Oral, paracetamol, it's not for severe pain. Because any burn, it's a severe pain. So you have to be familiar with the scores of pain: no pain, mild pain, moderate pain, severe pain. Sometimes they will mention in the scenario, okay? If the patient, for example, here looking frightened, so it's a severe pain, okay? Very quiet, it's a severe pain. Burn, so it's a severe pain. Long bone fracture or dislocation, severe pain. Appendicitis, sickle crisis. Unlikely to give you appendicitis or sickle crisis to test your skills in pain management. So they can give you a scenario of burn or scenario of long bone or dislocation. So here regarding the severe pain, you can consider Intonox, and you can consider intranasal diamorphine. You can consider IV morphine, but after diamorphine. Okay, 13 months, upper respiratory tract infection, compromise the airway, and needs rapid sequence induction. So your FY1 ask you for advice regarding rapid sequence induction using ketamine in pediatric and contraindication.
Active upper respiratory or lower
Stage.
D.
Asthma.
And lower respiratory tract infection.
What do you mean by the age?
Age less than 12 months.
But the age is 13.
Yes.
Contraindicated.
Yes, the mistake, if you are memorizing without understanding. Okay, so one of the contraindication
active respiratory tract
of the ketamine, age less than 12 months. Okay, but here the age is 13. Okay, so age here, it's not suitable. Clear, guys? Uncontrolled epilepsy, it's one of the contraindication, right? Uncontrolled epilepsy, but
not involved in this scenario.
Did they mention the patient has seizures here?
No.
Did they mention the patient has seizures and not controlled? Even seizures in the scenario, it's not contraindication. They said uncontrolled. It means if the patient has epilepsy, do you think epilepsy is contraindication?
No.
So uncontrolled epilepsy. Age is contraindication? No. Age less than 12 months. Clear? Okay. Do you think asthma is contraindication? It should be active asthma, or at least in the scenario, the patient has active asthma. Okay. So active upper or lower respiratory tract infection, because the patient has already in the scenario upper respiratory tract infection. Okay. So here they said high risk of laryngospasm, like active respiratory infection or active asthma. Okay. So we choose one because already mentioned in the scenario. Okay, 5 years, SOP with this compromise the airway needs rapid sequence induction. What do you think, you guys? Why?
Asthma. asthma.
Yes,
Age.
because already because the patient already has active asthma, right? Presented with severe SOP wheezes. Why asthma here? Why it's not bronchiolitis?
Wheezing.
Because of the age.
Yes.
More than 2 years.
Yes, excellent. If the patient has more than 2 years, age more than 2 years, it's asthma until proven otherwise. If less than 2 years, then think about bronchiolitis.
Dr. Honey,
Yes.
you said more than two. I thought it was more than 4 or 4.5 years you start diagnosing asthma. Then between 18 months to 4.5 years is viral induced wheeze.
For the purpose of the exam, if they
Yeah.
give you the age less than 2 years and wheezes, think about bronchiolitis. If they give you more than 2 years, think about asthma.
Okay, all right.
Yes, for the purpose of the exam.
Sure, thanks.
Welcome. That's why also the doses of salbutamol, they will say, for example, 2 to 5 years, you give blah, blah, blah. More than 5 years, give blah, 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 and so on.
Okay, sure.
Here, why we did not use age, because already more than 1 year. We did not use uncontrolled epilepsy because no epilepsy. We did not use active upper or lower respiratory tract because the patient doesn't have respiratory tract infection, right? Proposed procedure within the mouth. The patient is not using any procedure in the mouth. So asthma, it's suitable here. Same scenario, but 5 months here. Okay.
Age. Very good.
Yes, the age. So here, why contraindicated ketamine? Because of the age. And here, why? Because of the age? Because less than
5 months.
12 months.
1 year.
12 months. Uncontrolled epilepsy, it's not applicable. Asthma, not applicable. Intraocular pathology, it's a contraindication, but not applicable, right? They did not mention anything relevant to eye here, right? They did not mention anything relevant to mouth. So all are contraindications, but the one applicable age. Okay, what is your advice regarding contraindication of ketamine?
Proposed procedure within the mouth.
E.
E.
Option E. Proposed procedure within the mouse.
Yes.
Okay, the patient
Uncontrolled epilepsy.
They said the patient has severe laceration in the tongue, needs suture. So any proposed procedure within the mouth, it's a contraindication for ketamine. Clear? They said here.
Yes.
Proposed procedure within the mouth or pharynx. So it's a contraindication. This one is applicable or not?
Yes.
Because already
Applicable.
anything you mention in the scenario applicable. Regarding the age, applicable?
No.
Epilepsy applicable? He doesn't have seizures here. Asthma, he doesn't have wheezes. Intraocular pathology, he doesn't have eye problem here, right? Okay. What is your advice regarding contraindication of ketamine?
Uncontrolled epilepsy.
Yes, why?
Because he came with seizures.
Because patient present seizures.
Yes, so it's not about to memorize, guys, guidelines. It's not about to memorize flow charts. You should understand, okay? So it's not about, they will ask you what is the contraindication. No, the contraindication applicable in this scenario. Patient has seizure. Seizures, it's a contraindication? No, uncontrolled epilepsy. So brought by parents with compromised airway, not responding to maximum medical treatment. What does it mean, not responding?
Uncontrolled.
Uncontrolled. What if the patient responded to lorazepam? So no need for ketamine here, right? Okay. What is the most appropriate induction agent for rapid sequence induction in this patient?
Ketamine.
Ketamine.
So here his age is 35. Okay, we are discussing pediatric, but I try to put the age. I want you in the exam to think about everything. Check the age, check the gender, check the symptoms. What is the main complaint, and so on. Be familiar with everything. So here, ketamine in this age, it's the most appropriate. Okay, 15 years, so pediatric. Distal femur fracture, as you see in the X-ray. Is in severe pain, agitated, aggressive. Any fracture, severe pain. Even he did not mention severe pain, of course, he's in severe pain. His observation normal. Next course of action. What do you think, guys?
Ketamine.
Ketamine idea IM.
Fascial block.
Femoral block.
B, C. C.
A, B, C, D, or E?
C.
B.
B.
C, C.
B. B.
A.
No, it's not B.
B.
C. It's A, it's not B. It's A.
Okay, so in babies, ketamine is very good option. Okay, why we did not use fascia iliac nerve block? Is
because
the patient
yeah.
Okay, so distal femur different than neck of femur, right?
Yeah.
So if neck of femur or hip, you can use nerve block.
Yep.
Okay. Propofol, why we did not use propofol?
Is for GA.
Propofol is sedation or analgesia?
It's
sedation.
Sedation.
Sedation, not analgesia.
Yeah.
The patient will sleep.
Mm-hmm.
Okay. But ketamine, it's sedation and analgesic, right?
Yeah.
Sedation and analgesic. Okay. Fentanyl also it's
sedation analgesic.
But it will cause respiratory depression. So the best option here, ketamine. Okay.
Dr. Hani,
Dr.
if a
Hani,
fracture, neck femur
why
fracture,
didn't we use
the B
femoral
or C?
block?
If neck of femur fracture, I will use fascia iliaca
Yeah.
better than
What of
femoral
C?
nerve block. Why fascia iliaca, guys? Why fascia iliaca is preferred than femoral nerve block, even for the Royal College?
More safe and also can
It's not more safe.
size
It's not more
Block
safe.
all the nerve.
It blocks the nerves. All
It
the
blocks
nerves.
3 nerve.
Yes, excellent. It will block 3
Hmm.
nerves.
lateral QT.
Femoral, it will block femoral only. But fascia iliaca, it will block 3 nerves. Femoral plus obturator,
Lateral cutaneous nerve.
lateral cutaneous nerve of the foot.
Lateral.
Okay? Both of them will block thigh and leg. But fascia iliaca, it will block more area. Okay? Okay, regarding 15 years, neck of femur, he's in severe pain. You planned for fascia iliaca nerve block. Why? Because of
Neck of femur.
Neck of femur fracture.
what is the muscle below the landmark?
Iliacus.
Okay, so your target here, right? This is a needle.
Yeah, iliacus.
So how many nerves? 1, 2,
3.
3.
Yeah.
Okay, so 1, 2, 3. Okay. So here iliacus, it will be below the landmarks. Okay. So take care. This question is important. Which nerve is blocked? Fascia iliaca nerve block.
Femoral operator.
Femoral nerve
D.
of the
Is D.
lateral femoral cutaneous. Or
Is D.
3 nerves.
Okay, so femoral obturator lateral femoral cutaneous nerve. Okay. What is the maximum safe dose of plain
2 mg per kg.
2 milligram.
Two milligrams per kg.
It's a very important record.
Yeah.
Okay. So 2 milligram. What's the next course of action? I think this question repeated.
Repeated.
Yes.
Keep the mind game.
Okay. Okay. We will go for batteries. This topic is very, very important. Okay. So if the patient has no X-ray in the, I'm talking for the purpose of the exam, you find scenario of batteries. What is the first action in scenario of batteries, guys?
Just enough.
Is E.
X-ray.
X-ray. Yeah. X-ray.
Patient child by his father, and he has ingested accidentally. It's a different if they say accidentally or intentionally. Okay. 4 hours ago. Why 4 hours ago?
To cross the stomach.
No, I mean why they mention 4 hours ago? Because the borderline is 24 hours.
Observation.
Observation. Okay.
It's not about observation. I mean, we will see now the criteria for discharge. If the patient presented within 24 hours, it's good. If presented within more than 24 hours, it's a bad sign. Clear? Okay. No past medical disease, it's good. The patient can tolerate oral intake, it's good. No symptoms, it's good. So 4 hours, it's good. Accidentally, it's good. Clear? So if you find the accidentally, It's a good point. 4 hours, it means within 24 hours. It's a good point. Patient has no symptoms now, it means he's asymptomatic, so it's good. No past medical disease, no comorbidity, it's good. Can tolerate oral intake, it means good. It means he doesn't have any symptoms of intestinal obstruction. So what is the action now, guys?
X-ray serious, chest and abdominal.
Okay, so you will do chest X-ray and abdomen X-ray with the patient lying down. Ideally, AB should be requested to assess both the position of any magnets and the number of magnets. Okay, so did they mention here lateral view?
No.
Why? The lateral view, if you did not find
In the
more than one battery in this view, so you will do chest X-ray, abdomen X-ray. If you find the 2 batteries, no need to do lateral view. If you find only 1 battery, so you can do lateral view. Okay. So this is a flow chart, and this is these are the batteries as you see here. Okay. We will review together. So, witnessed or suspected rare earth magnet ingestion or unexplained GI symptoms with rare earth magnet in the child environment. Follow toxibase advice whilst following the flow chart, this flow chart. Okay, what is the first action, guys? So,
X-ray.
any scenario without X-ray, the first action you will do X-ray. It will be chest X-ray, abdomen X-ray with the patient lying down. Lying down. Ideally, AB view. Then request lateral abdomen X-ray. Lateral abdomen or lateral chest?
Abdomen.
Abdomen only. When to do that?
Single magnet.
Okay, so if they give you single magnet, what is the next action?
Request lateral X-ray.
Yes, request lateral X-ray. Okay, abdomen X-ray. Okay, so after lateral X-ray, you find the X-ray is showing only single. So the first X-ray single, the second X-ray single, and the patient has discharge criteria. What are the discharge criteria? Single magnet. Number 1. Accidental ingestion. Number 2. No comorbidities. Number 3. The patient tolerating oral intake. Number 4. Presence within 24 hours of ingestion. Caregiver can provide close observation. So if the patient has single magnet in the first X-ray, in the second X-ray, and he has discharge criteria, what you will do, guys? Discharge.
You discharge there with safety net.
Yes, discharge, and he will repeat X-ray every
6 to 12.
He will repeat X-ray every
6 to 12 hours.
6 to 12 hours. Clear?
Yep.
Okay. We will go for the other possibility. You did the first
6 to 12.
X-ray. X-ray, and then you did the second X-ray, you find multiple magnets. What you will do? Discussion with
surgeons.
Yes, surgery. Any local surgery or pediatric surgery?
Pediatric surgery. Pediatric.
Okay, so when to choose this option? So each box, guys, each box, it will be option in the exam.
Yep.
So this option, discussion, remember that, urgent discussion with the specialist pediatric surgical center. So a specialist pediatric, it's not general surgery. Clear? It's
Yep.
Specialist pediatric. Okay, so when to choose this option? If you find in the scenario symptoms of
intestinal obstruction
There's no obstruction.
or
multiple magnet.
Multiple magnet.
yes, more than enough. So if you find X-ray of 2 magnets, you will go directly for a specialist pediatric. If you find symptoms or evidence of intestinal obstruction, go directly for a specialist pediatric surgical center. Okay.
Yep. Yep.
What if the patient has single magnet and he doesn't have any of the discharge criteria? You will discuss, but
Pediatric surgery.
with local surgical team. It means plus minus pediatric. General surgery in the hospital for what?
Admission.
For admission and the close observation and repeat X-ray. Clear now?
Yes.
Yeah.
Okay. Okay. So we will go for questions. So they give you single or multiple?
Single.
Okay. What's the next course of action? You have to check the patient has criteria of discharge or not. So accidentally, it's a criteria of discharge?
It is, yes.
Yes.
Within 24 hours? Yes.
Yes.
No symptoms?
Yes.
Yes.
No comorbidities?
Yes.
Can tolerate?
Yes.
Yes.
What is your action?
Discharge.
Repeat X-ray. Yeah.
Lateral X-ray.
It will be discharge, or you will repeat lateral X-ray.
Discharge.
Repeat.
It will be lateral X-ray.
Lateral X-ray.
Wait, guys. When to discharge the patient? If he has first X-ray, single. Second X-ray, lateral view, single. Clear?
Yes.
So we should choose lateral X-ray. Do we have lateral X-ray here in the options?
No.
No.
Not applicable. If we have, we will choose. So what is the next action?
B.
Repeat.
Repeat abdomen X-ray should be performed after 6. It means it is a charge, right?
Yes.
There's a charge and repeat. Okay. So if you find here repeat X-ray 6 to 12 hours and you find the lateral X-ray, which one you choose?
Lateral X-ray.
Lateral X-ray.
Okay. But because it's not available, I have to choose this one. I am forced now. Okay. Okay. When to discuss with a specialist regional pediatric surgical center? 2 options or 2 indications.
If any
More than one magnet and intestinal obstruction.
Yes,
multiple magnets.
intestinal obstruction or multiple magnets, right?
Yes, sir.
Yeah.
Okay. When to admit under local surgical team?
If discharge criteria not met.
Single magnet. the patient has no criteria of discharge, right? So here he went to admit under local surgery if the patient has no criteria of discharge. Clear? No criteria of discharge. It means if I find the patient here has symptoms now, right? Or he presented within 24 hours, more than 24 hours. I will choose what?
Admission.
Admission and care of
Cannot tolerate. I will choose what?
Surgical.
Admission.
Admission
Care
under
of
local
surgical.
surgery.
Yeah.
So if the patient has criteria of discharge, and repeat every 6 to 12 hours. If the patient has intestinal obstruction or multiple magnets, you will discuss with
Specialist regional pediatric.
pediatric surgeon center. If the patient has no criteria of discharge and he has only single, you will admit
Admission under the care of local surgical team.
Clear now?
Yes, sir.
Yeah.
Okay. Okay. What's the next course of action? So the patient here accidentally, is it criteria of discharge?
Yes.
4 hours?
Yeah.
Yes.
No
Yes, sir.
symptoms?
Yes.
Yeah.
Yes.
No past medical disease?
Yeah.
Can tolerate?
Yes.
Yeah.
Single?
Yes.
Yeah.
What's the next course of action?
Lateral
Lateral
X-ray.
X-ray.
Lateral X-ray.
Yes.
Request lateral
So
X-ray.
first X-ray, it will be AB view, chest and abdomen. The next X-ray, it will be lateral X-ray. It could be abdomen or chest.
Abdomen.
Abdomen.
Abdominal.
Yes. Okay, this one.
Admission under the care of local surgical team may be appropriate.
Admission.
Option C.
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 So the patient here accidentally is it criteria of discharge?
Yeah.
Yeah.
Yes.
4 hours within 24 hours.
Yes.
Yeah.
Has comorbidities.
It's not in criteria.
Not for this case.
No.
Not for discharge,
So
for
you
admission.
cannot discharge. You should call you should discuss with local surgery or with
Surgical.
center pediatric center.
Local
Local.
Local surgical.
Local.
Surgical.
And because it's a single, right?
Yes, sir.
Cannot tolerate oral, so he cannot be discharged, right?
Research. Yeah.
What's the next course of action?
Admission. Without the clear
Admission
of
under
local
the care of
surgery.
local surgical team.
Okay, cannot tolerate oral. Is it intestinal obstruction or is it
Intestinal obstruction.
No. Not discharge criteria.
Pediatric surgical care.
admission under the care of local surgical team? Why? Because it's a single. Okay. And the patient has comorbidities, you cannot discharge, right? Okay, so if the patient doesn't have criteria of discharge and still single, you have to discuss with local surgical team. Okay. Accidental, 4 hours, no symptoms. Until here, you have criteria of discharge, right?
Yeah.
No past medical disease. X-ray, AB, and the lateral done. AB and the lateral done. You plan to discharge the patient and repeat abdomen X-ray after 6 to 12 hours. After 1 hour, you received a call from the father at home that the patient has abdominal pain, vomiting, and not tolerating oral. What does it mean, these symptoms?
Spinal obstruction.
Intestinal obstruction. Bowel obstruction.
So what is the action?
You should discuss with the regional pediatric
Specialist.
Clear now? So if you find the intestinal obstruction or multiple magnets, you can discuss with center, specialist pediatric surgical center. Okay?
Sorry, Dr. Hani.
Yes.
Why not endoscopy?
Why not endoscopy? Endoscopy, it will be the last option. Okay. Endoscopy here, discussion with a specialist pediatric surgical center to make plan for further imaging observation plus minus removal. When to remove your question? When to do endoscopy?
When it's accessible.
Yes, I don't want to confuse you from the start. I am trying to escalate questions to understand. So if the patient, you will discharge and repeat every 6 to 12 hours. If you find the magnet is moving, so what you will do? Progression of single magnet. Okay, what you will do? You, for example, the patient has a single magnet in the stomach here, for example. You repeat it after 6 to 12 hours, you find here it's going down. After 6 to 12 hours, you find it's going down. So every time it's going down.
Observation. Yeah.
So does it charge? Not observation. Don't observe. You will discharge the patient. He will come every 6 to 12 hours to repeat the X-ray, not observation. Then what if the single magnet is progressing? What is your action?
Discharge.
Discharge with safety net. Okay. What if failed? What does it mean failed? The first magnet in the stomach, you repeat it after 6 to 12 hours, you find the same place, same location. After 6 to 12 hours, you find same location. What does it mean?
Not progressing.
Not progressing.
Failed, right?
Yeah.
But remains asymptomatic. What you will do? Discussion with?
You can have pediatric surgical team.
A specialist pediatric surgical center. Here, he will do removal. So removal here, it means endoscopy or surgery. Endoscopy to remove or surgery, exploration. So how many options in removal? Two. Endoscopy or exploration. Okay. So when to do endoscopy, do you think endoscopy will reach here?
No.
So if it's high, you can do endoscopy. If it's low, you can do cervical intervention. Please, guys, if you have children beside you, you can mute your mic. Or if you have noise beside you, you can mute your mic. Okay, so here regarding when to choose endoscopy, when to choose surgery, if they mention in the scenario you discussed with the specialist regional pediatric surgery and he decided for definitive management. Clear? It's not our action, right? So our action here, you can discuss, you can repeat X-ray, you can admit, you can discharge. But in endoscopic removal or surgical intervention, it's not our decision here. Clear?
Yes, sir.
Okay, but if they said you discussed with regional pediatric surgical center and they decided for definitive management, then what is the definitive management? It depends on the X-ray. If you find multiple magnets, you will choose which one, endoscopy or surgery?
Surgery.
Surgery. If you find down like this one, it will be surgery also. Otherwise, you can choose endoscopy. I wish it's clear. Okay, so accidentally, what does it mean?
Discharge.
It's
Criteria
optional.
of discharge. Criteria of discharge. One of the criteria of discharge, but doesn't mean discharge. 4 hours.
Criteria of discharge less than 24 hours.
Yes, the patient has no symptoms. Also,
Criteria.
criteria of discharge.
Criteria.
Of medical
Discharge
disease,
criteria.
criteria of discharge.
Criteria of discharge.
Can tolerate oral intake, criteria of discharge.
Criteria for discharge.
So here, X-ray showing
Multiple magnets. Multiple magnets.
KB and lateral X-ray.
Do you need lateral X-ray here?
You
Already
discuss
done.
with the specialist.
No need for lateral X-ray because already
Repeat after 6 to 12 hours.
because already it's multiple magnets, right?
Yes, sir.
So no need for lateral X-ray here. So if you find the multiple or intestinal obstruction, what is the action?
Discuss.
Specialist regional pediatric
surgical.
Clear now?
Yes, sir.
Okay. So if you find multiple magnets, you will discuss with a specialist pediatric surgical center. Okay. This one. X-ray done and shown below. So he has criteria of discharge and you did discharge the patient. Repeat abdomen X-ray after 6 to 12 hours. The magnet having not moved from last demonstrated position.
Endoscopic removal.
No,
No admission. When there is
it's admission with the care of surgical team.
Option C.
A.
So endoscopy, you will do endoscopy, guys?
No.
It's down in the
You will do endoscopy? No.
No.
So you will discuss with the specialist regional pediatric surgical center in the first instance. So again, failed. He said here you repeated what you find is the magnet not moved. So what does it mean not moved?
Failure.
Failed. What will you do? What is your action?
Discuss with the specialist pediatric.
Clear?
Yes, sir.
So he will decide for observation plus minus removal. Okay. Okay, so no symptoms, no past medical, the patient can tolerate, X-ray done, and so on. What is the next course of action?
This patient, no criteria for discharge, more than 24 hours.
Excellent.
Yes. No. So you need to do admission
because he doesn't have multiple magnets, he doesn't have intestinal obstruction, so no need for option A, right?
Dr. Hani, I have one question, please.
Okay.
The decision of multiple magnets, it is depending on the history that we take from the father, that how many batteries the child ingested
No. If the father said ingested, for example, 4 or 5 or 6, you have to do X-ray. Okay. And if the first X-ray it's showing single, you have to repeat lateral. According to the flow chart, right?
Okay, but I mean, if the father don't know the number or the child ingested only one, so we need to do lateral or no?
Here, doctor, witnessed or suspected. What does it mean, witness? The father, he saw him eating all magnets. Okay. What you will do?
Urgent erect.
Okay. And if
Call
you
the
find
specialty.
if you find the single, what you will do?
Lateral X-ray only if signal.
So you will depend on witness?
No, on a chart بقى خلاص we will take lateral X-ray if a single magnet.
Yes. Clear now?
To reassure يعني.
Yes.
Okay.
Don't depend. Everything in your life should be documented. Okay? Documented by X-ray. If the first X-ray showing a single, you have to do the second X-ray to be documented also. But if you find the 2 magnets in the first X-ray, no need to do the second one.
Okay.
So everything should be documented. So here, the patient in this scenario, single magnet, and the patient more than 26 hours, so he doesn't have criteria of the discharge. So what you will do? Discuss with local surgical team for what?
Admission.
So this box or this option in your hospital will be admitted in your hospital, but this one you will discuss with the specialist center. Okay, pediatric center. Okay. Okay. 4 hours, no symptoms now, can tolerate, discharge the patient already, and after 12 hours he came to you. You repeated X-ray, the magnet had moved. What does it mean moved? Successful or failed?
Successful, progressing.
Progressing. So X-ray repeat done and shown below. This one. Now it was, for example, here. Now it's here. So it's successful. What you will do?
Repeat X-ray. 6 to 12
Discharge.
hours.
It means it is a charge. You will discharge and then repeat again, right? right?
Yes.
Yes. So if the X-ray is progressing, you can discharge and repeat again. Progressing, you can discharge and repeat again after 6 to 12 hours. Clear?
Yeah.
Okay, I wish. Okay, X-ray done and shown below. You plan to discharge the patient, repeat abdomen X-ray should be performed. After 12 hours, you repeated abdomen X-ray. The magnet have not moved from the last demonstrated position. You discussed with a specialist regional pediatric surgical center. Why you discussed? Because you have more than
Multiple magnets.
Multiple magnets at this point, and
also not progress.
also not
Failure.
moving. Yes.
Failure.
Failure to progress.
Okay, and he decided for
Definitive treatment.
So what is the next course of action?
Surgical intervention.
Okay. Why surgery? Why not?
Because this is multiple magnets. You
And
cannot
the
do
position
endoscopy.
also. The position down.
Position also. Yes, yes.
Patient. Okay. Cleared now? This one?
Yes, sir.
Okay. So here regarding surgical intervention, indicated when endoscopic removal is not indicated. So the priority for endoscopy or for surgery?
For surgery.
Endoscopy.
Endoscopy, yes.
I am talking in general. In any surgery, what is the priority? Endoscopy or surgery?
Endoscopy.
If not indicated, you will go for
Surgical.
surgery. Clear? Okay, because this one is better, endoscopic removal better. But if endoscopic removal is not indicated or not possible because of the location, the number of magnets, or several bowel loops, if they show you X-ray and all bowel loops together, or any signs in the X-ray for intestinal obstruction, you will go for surgical intervention. Because you have to open or explore the abdomen by any way. Okay, which of the following is the most appropriate oral endotracheal tube? What do you need from the scenario? Age.
Age. Yes.
Only age. If you find this scenario, you need only the age. So what do you think? Oral.
Lens. You want the lens?
Yes.
Age
He wants the lens and the oral also. Age is 2. What do you think?
Is it 14?
I think it's 14.
8/2 plus 12.
14?
Okay.
13. Okay.
So the age divided by 2 plus 12. So it means 2 divided by 2, 1 plus 12, 13, right? And what about nasal? Age divided by 2 plus Okay. So this question, nasal endotracheal tube.
16. Oh, 16. 16.
15.
It's 16.
Okay, so age divided by 2 means 1 plus 15 means 16. Okay. So they can ask you in the exam. This is very common question and a very important question. You can expect you have to memorize this slide before the exam. You have to memorize cuffed ET tube, uncuffed ET tube. And you have to memorize the lens, oral and nasal. Okay, so I want to use cuffed, I want to use uncuffed. According to the Royal College, they mention this Resuscitation Council, the website of the Resuscitation Council, as you see here, guidelines 2021. They said tracheal tubes, cuffed TT are recommended where
Pediatric.
so any pediatric think about
Cuffed.
Cuffed.
cuffed, except
Neonates uncuffed.
except in units. Okay, so in unit you will use uncuffed. Okay, so any pediatric in the scenario. If they give you scenario in the exam and they ask you about the size of the tube, the width, so you will calculate according to cuffed or uncuffed.
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 Why uncuffed?
Unit.
I did not say neonate. I said if they give you pediatric, they ask you for width, you will calculate for cuffed or uncuffed.
Cuffed.
Clear now?
Yes, sir.
Okay, so memorize cuffed. It will be age divided by 4 plus
3.5.
3.5.
Okay, so pediatric again, age divided by 4 plus 3.5. For example, the age is 4. 4 divided by 4
1
plus
1
3.5, it's 4.5. Clear? So they will not mention like this scenario 4 years, and they ask here which of the following is the most appropriate endotracheal tube width to use in
You
this.
will not mention the time.
What do you think?
4.5. 4.5.
4.5.
4.5.
4.5.
Yes. So 4.5. Did they mention here cuffed or uncuffed?
No.
But because pediatric, you will calculate for what?
For cuffed.
Cuffed. Okay. So age divided by 4, it means 1, plus 3.5, it means 4.5. Clear?
Yes, sir.
Don't wait for cuff or uncuffed in the options. Okay, if you find this age is neonate, you will use
Uncuffed.
uncuffed. Okay. Okay. What alternative diagnosis should be considered in this patient? So the patient 4 years, mild corizing.
Sorry, Dr. Hani.
Yes.
For the formula for neonates, it usually they said age in years.
Yes.
So, but
Excellent.
neonate,
In neonate, do you think he has age? No.
Wait.
No, I mean here you can say age divided by 4. For example,
Will be considered 1?
no, you can consider 0. Okay. For example, the patient is 1 month neonate, for example, or days. It will be nothing, right? You can consider, for example, 0. So 4 plus 0.
4.
It will be 4. But if newborn, it will be
Fixed size.
3 or 3.5. Clear?
Okay.
Clear, doctor? You asked me about the neonate and the
Yes.
newborn.
Yeah. Play.
In a newborn, if you find a newborn in the scenario, unlikely the Royal College for sure they will not ask you about newborn, so you will use 3 or 3.5. It's not logic. They want you to test they want to test your skills. So here no skills at all because it's fixed. Okay. And regarding the neonate, for example, it will be 4. Okay. So not logic here to ask you about this question.
Thank you.
Okay, so this patient, he has mild coryzal symptoms. The 24 hours, unwell, developed harsh cough. What does it mean, cough? It can be croup, it can be epiglottitis, it can be
Bacterial tracheitis.
yes, bacterial tracheitis. Product of copious secretions and hoarse throat. Temperature 39.5, respiratory stridor, respiratory distress. No dysphagia or drooling. So you ruled epiglottitis. Initially, HGB diagnosed the croup and administered dexamethasone, but the patient has not responded. What does it mean not responded? It's
not croup.
It's not
croup.
The staff already administered nebulized adrenaline, but again the patient shows no signs of improvement. It means it's
Bacterial tracheitis.
Yes, bacterial tracheitis. So how to diagnose bacterial tracheitis? Not responded to dexamethasone
Or group.
and no improvement with adrenaline. So you can think about bacterial tracheitis. Why not pneumonia?
Spider.
Why
There is a
not pneumonia?
presence of spider.
Copious secretion.
Copious. The patient has also respiratory stridor. Okay. Asthma, why not asthma? They did not mention with this. Bronchiolitis, unlikely in 4 years. Bronchiolitis, unlikely in 4 years. Okay. 5-week-old boy brought to the pediatric by his parents. He has nasal congestion, cough, wheezes. So wheezes for 3 days in 5 weeks. What is the diagnosis?
Bronchiolitis.
Okay. On arrival, he's pale, lethargic. Okay. So the question here, when to give oxygen? This is common recall.
Less than 92.
Why less than 92?
Because he is less than 6 weeks.
5 weeks. Yeah.
We have 2 options here, less than 92. Which option, D or E?
Less than 92 persistently.
Persistently, yeah.
Yes. Can you see? If you follow the guidelines, you will find this one. This is screenshot from NICE guideline. You will not find in a book. So if you follow books, you will not find this information. Okay.
Its neonate is 92 and other more than neonate it's 90.
No, not neonate. If 6 week borderline.
Yes.
So 6 weeks and over should be less than 90 persistent.
Persistently, yeah.
If the patient under 6 weeks or he has health condition, any comorbidities, it will be less than 92 persistent. Clear? Okay, that's why we chose here SpO2 less than 92 because the age is less than
5 weeks old.
6 weeks.
5 weeks old.
6 weeks, less than 6 weeks.
Less than 6.
So this is the answer, appropriate answer. Okay. When to give oxygen 6 weeks?
B. SpO2 less than 90.
90
Resistantly.
resistantly.
Less than 90. So 6 weeks or more, when to give oxygen? 90. Okay?
90.
Resistant to 90. Okay. Did they mention here the patient has heart disease, kidney disease, or any comorbidities? No. He has no murmur. It means no problem. Okay. Okay. So in this scenario, 10 weeks. What does it mean, 10 weeks?
More than 6
More
weeks.
than 6
More than 6 weeks. Okay. So he went to give oxygen in more than 6 weeks.
Less than 90.
Is persistent.
But the patient has kidney disease.
Less than 92. Persistently less than 92.
Yes. So if because of kidney disease, any age,
Unsignificant.
Okay, so if you find the kidney disease, ignore the age.
Right.
And then SpO2 less than 92, you can give oxygen. Okay. If the oxygen saturation is more, what does it mean less than 92? On air or on high flow oxygen?
On air, on air.
Of course, in air, because he said when to give oxygen. Okay. So any patient with bronchiolitis, give him, you can check pulse oximeter for oxygen saturation and check. After 5 minutes, for example, the patient oxygen saturation is still low, less than 92, then you can give oxygen. Otherwise, no need to give oxygen. Okay. So healthy condition or under 6 weeks and less than 92, you can give oxygen. Thank you, guys. I wish you all your best, and inshallah, please send any recalls or anything like that. I will formulate and I will discuss with you in the group, inshallah. Okay.
Sorry, Dr.
Thank
Hani.
you so much, Dr. Hani. Jazakallahu khairan.
Dr. Hani, sorry.
Yes.
Please, can you go through the last question again? The one with the kidney disease, please.
This one?
Yes.
Yes, if the patient has any health condition, so it will be less than 92, like this one. Any health condition, we want to give oxygen if less than 92 persistent. Clear?
Okay, all right. Thank you very much, sir.
Welcome. Okay. Thank you, guys, and bye.
Thank you, Dr. Hani.
Bye-bye.
Thank you, sir.
Thank you, Alex.
Jazakallah.